Oh, hi, I'm Janako. In this presentation, I will present some of the common pathological lesions of the shoulder joint. Rotator cuff tears are very common on sonographic examination of the shoulder and are classified as complete tears. In a complete tear, you have a complete split of the tendon into two parts, and then you have a full thickness tear where the tendon is torn and has a hole in the tendon from bursal surface to the articular surface. That's a through and through hole, but the tendon does have intact surrounding fibers. Then you have an articular surface tear when the tear is limited to the articular surface of the tendon. And then you have a tear which is within the substance called intrasubstance lesions, and the another tear which is limited to the bursal surface is called bursal surface tear. And a very special tear called a rim rent is a tear which is in the most distal part of the tendon at the insertion to the greater tuberosity on the articular surface. It's called a rim rent tear. Cartilage interface sign is an echogenic line above the cartilage which results from the difference in impedance between the cartilage and the fluid in the space above the cartilage. It is an indication of a large longitudinal tear in the tendon. Here is an image of a supraspinatus tendon which shows full thickness tear with hypoechoic non-fibrillar material filling the space and creating a cartilage interface sign, a hyperechoic line between the cartilage and the fluid above the cartilage. Here is another image of rotator cuff tear. The rotator cuff tear, mainly the full thickness part of the tear, is seen involving the infraspinatus tendon, and you have another part of the tendon which is intrasubstance, which appears to be at about the junction of the supraspinatus and the infraspinatus tendons. Here is another example of a supraspinatus tendon tear. What you're seeing in this image, you do not see the tendon at all. So it's a complete tear of the tendon with the herniation of the deltoid on the top of the greater tuberosity, also known as the naked tuberosity sign. Here is an example of the calcific tendonitis. You see that here is the calcific deposit at the insertion of the supraspinatus tendon to the greater tuberosity. You're not seeing the tuberosity. Why? Because here is your posterior acoustic shadow which is shadowing the greater tuberosity, and you're unable to see that. The reason is because this is high attenuation lesion, but it eats up your sound and there's not much sound left to image the tissues deeper to it. So this is called acoustic shadowing from the calcification at the greater tuberosity. You're seeing the calcific tendonitis. Here is another example of calcium deposits in the tendon. You see that here is calcium deposits in the tendon. Again, here on the short axis, the tendon is clearly gone. I don't see much of the tendon left, but I don't see the posterior acoustic shadow. So this is a kind of soft calcification which is non-shadowing. It does not create posterior acoustic shadowing. It does not eat up your sound as much as the hard, the high attenuation calcific lesions. Here is an example of tear and calcification in the biceps tendon. What you're looking at the biceps tendon. You have the biceps tendon fibers here, but here you have a complete lack of fibers with hypoechogenicity and hyperechoic calcific deposits in the tendon. And here is the short axis scan. You see the biceps tendon in the bicipital groove, and you see the calcific deposits on the tendon. Here is your subscapularis tendon, which is also hypoechoic because of the direction of the beam to the tendon. Here is an image of the AC joint. So look at the AC joint. Just look at the whole hypoechoic stuff filling and spreading all across. And in this joint, what I observed was a fluid pumping up through the AC joint from the glenohumeral joint, and when the fluid, because of the full thickness tear, is coming from the glenohumeral joint and shooting up through the AC joint, is called a Geyser sign, and it creates a pseudo cyst at the AC joint. Well, here is an example of a large effusion in the subacromial subdeltoid bursa. You see in this longitudinal view of the subacromial subdeltoid bursa. Here is your deltoid, skin, subcutaneous tissue, greater tuberosity, and here is the attachment of your supraspinatus tendon. I do not see much of the supraspinatus, but the supraspinatus in this patient was completely normal, which I observed after draining this huge amount of fluid from this bursa. And here you see the same bursa on a short axis scan. What you're seeing here, you're seeing the deltoid on the short axis fibers, and you're seeing the fluid in there, and you have a bicipital groove and the biceps tendon sitting in there. And so again, anteriorly at the area of the biceps, I tried to take another scan. You see the biceps tendon, beautiful clear biceps tendon, huge amount of fluid, deltoid fibers in the longitudinal axis. So this was a person with a large amount of effusion in subacromial subdeltoid bursa. Here's another example of subacromial subdeltoid bursa. This is demonstrating the compressibility of the fluid in the subacromial subdeltoid bursa. If you see these two scans, you're seeing that one is the long axis scan and here is the short axis scan. You could really recognize these pictures from the orientation of the deltoid fibers, and it's showing you that here is your subacromial subdeltoid bursa, which is compressible with the transducer indicative of fluid in the bursa. Now this image shows hypoechoic widening of the glenohumeral joint. You see the glenohumeral joints, and the glenohumeral joint is completely filled with this hypoechoic material, which is a synovial proliferation. The definition of synovial proliferation is a hypoechoic material filling the joint capsule with or without Doppler signal. Here is an example of dynamic image of the glenohumeral joint. What you're looking at in this joint, you're seeing a small amount of fluid which comes up on the external rotation of the joint when you see that, because which could have been missed on the static scanning of this joint. Now this slide shows you an image of glenohumeral joint with the fluid in the glenohumeral joint, but the main component which I want to show you in this slide is the calcification of the glenoid labrum. Here is your joint capsule, which I'm trying to draw. Here is your joint capsule. So if you compare that, here in this joint capsule. So now here is the calcified labrum. Here you see this labrum which is called calcified. Here is the labrum which is calcified. Now you clearly try to look at it. This is your spinoglenoid notch, and here is the glenoid coming up right here. The glenoid coming up right here. You have to be very critical when you're trying to watch this. So that's why I tried to draw it for you. Here's your glenoid, and then you see the calcified labrum here, and here is your labrum, and here is your joint capsule. And here is a fluid, hypoechoic fluid, filling the glenohumeral joint. Another image showing you the fluid in the glenohumeral joint. Here is the humeral head, here is your calcified labrum, and you're not seeing the glenoid much here, but here you're seeing the capsule. Again, here is the fluid in the glenohumeral joint. Now, here in this image, what you see is you're seeing the biceps tendon, seeing the widening of the synovial sheath of the biceps tendon. Now, the widening of the synovial sheath of the biceps tendon is an indication of effusion in the glenohumeral joint, because the synovial sheath of the biceps tendon is a prolongation of the synovial lining of the glenohumeral joint. Now, here is another example of widening of the synovial sheath of the biceps tendon. This was totally unique and different. At first point, I thought this person may have a fluid in the glenohumeral joint when I looked at this and looked at this. But when I scanned it in a dynamic scanning, I saw that this the widening was limited to just this area, and the glenohumeral joint was clean. So this was a pretty limited synovial proliferation along the biceps tendon limited to the mid portion of the biceps tendon. Now here is an image of the biceps tendon on dynamic scanning on the external and internal rotation of the arm, and this indicates the subluxation of the biceps tendon. Here is your biceps tendon in the groove, and here is the subluxating biceps tendon which gets out of the groove and gets on to the lacetal velocity. Now let me show you some of the examples where the ultrasound helped me a lot. Without ultrasound I will not be able to make a diagnosis. Here is an example of a 15-year-old girl who was hit by the football on her shoulder, and she had an X-ray done which was normal, and she was referred to me for evaluation of the shoulder with the ultrasound. I examined her shoulder from all the basic simple protocols, did not find anything. The only way I was able to find this lesion is because of the patient's complaint. And she complained that my pain is right at this area on the side of the shoulder. So I was really astonished to see this lesion. Here is your deltoid, and here is just below the greater tuberosity and the attachment. You have a tear in the deltoid. Here is your long axis scan, here is your short axis scan and of the tear on the deltoid muscle. So it's very important you pay attention to the patient's complaints, and that's how you could discover certain things which you will not find on the scanning otherwise. Here is another example of somebody who came to see me asking for a shot in the shoulder because he had been a regular patient. He has been getting shots as needed, and he has been pulling some rods and suddenly had a pop and then developed a pain in there. I asked him, I said, what is this? What happened? He said, I don't know. And then I looked at his arm. I said, what is this? I don't know. And I compared both these arms. So here you could see clearly something people they describe as Popeye sign, indicative of the tear or the rupture of the long guide biceps tendon. So I placed my transducer, and I was astonished to see that on both views he had a tear, almost complete tear of the biceps tendon. Here is another example of some strange discoveries with the ultrasound, and this is a patient who is a 74-year-old man with a left shoulder pain for 2 to 3 years, and he had a history of rotator cuff surgery about 15 years ago. He was sent to me by his buddy and who told me that go to my doctor who is going to give you a shot. So he came to me requesting a shot. So in the examination of the shoulder, what I found that when I tried to rotate his arm externally and internally, so look at on the internal rotation, his shoulder just pops up. So he was dislocating his shoulder on internal rotation. So I told him, you don't need a shot, you need an orthopedic doctor, which was not interested to go